Good morning and good afternoon. We will get started shortly as everyone finishes entering the webinar. Okay, so in the interest of time, we can go ahead and get started with this, and then we will have people continue to join as we do our introductions. So thank you so much today for joining our webinar, Building Scalable Collaborative Care Models, Integrating Design, Pilot Execution, and Sustainability. We would like to just give a high-level overview and a thank you from the Association of Cancer Care Centers. We're a how-to organization that works on translating clinical findings into ways that can be effectively introduced into clinical guidelines and effective practices. We're a community cancer center organization that has now expanded to cover private practices, hospital-based practices, large health systems, and academic medical centers. And we have a multidisciplinary representation, everyone from navigation to the clinical team to financial, IT, and the executives. We would like to also thank our partners for this webinar, the Association of Oncology Social Work and the American Psychosocial Oncology Society. And with that, I am excited to introduce our advisory committee and guest speakers today supporting this program. Dr. Jessie Fan is the medical director of the Department of Psychosocial Oncology at Fred Hutch. We have Dr. William Pearl, who is the chair of Department of Psychiatry and Behavioral Health at Memorial Sloan Kettering. And we have a guest speaker today with us, Dr. Carrie Wu, who's the clinical director of collaborative care and satellite programs at Dana-Farber Cancer Institute. Our learning objectives today are to describe the key components and processes involved in planning, piloting, and scaling collaborative care models. We'll help identify the types of data needed to measure pilot outcomes and supportive program sustainability, and apply strategies for designing scalable and sustainable integrated models with clinical practice. There are 2 disclosures around consulting from our speakers. And with that, I will turn it over to Dr. Fan. Thank you.
Great, thank you. So what I'd like to do today, and I think it's going to be an introduction to what Dana-Farber and Memorial Sloan Kettering are also doing, but I'd like to give a overview of the journey that we took at Fred Hutch. I want to focus particularly on the pilot and sustainability aspects, but I think that it'll be helpful to also provide some context in terms of how we were able to get to the pilot in the first place. Next slide. So really, we started with an idea back in the late 1990s of launching a pilot of collaborative care. The evidence base for the chronic disease model and the collaborative care model, I felt was really strong and really set up well for implementation in the cancer setting. And this is what we had in mind and proposed to Fred Hutch. And when Fred Hutch integrated with the University of Washington, there was really a strong imperative for us to serve a really large population of patients in a more efficient way, which are our referral model was not meeting the needs for. So we developed a vision and a plan that would be ready to implement when the time was right. As you can imagine, when we merged with University of Washington and Fred Hutch, there were lots of competing agendas, and I really made it a point to use any positive outcomes as good examples of what good psychosocial care could provide. But when there were outcomes that weren't so positive, I was very intentional about pointing out that things could have gone better if X, Y, and Z was available. And for example, we could be screening better, we could be providing better evidence-based care. We could be providing more timely treatment adjustments, things like that. And that, I think, planted the seed in a lot of people's minds that, gosh, we really need a more robust psychosocial program. And then this was around the time, in the 2000s, early 2000s, 2010s, that the policies and expectations, standards of care were really developing, and we were able to leverage these new standards of care to our advantage as well. Next slide. So other facilitators, I think, that led us to the ability to do our pilot was that I was able to really nurture the relationships with the champions in oncology, social work, psychiatry and psychology, center and service line leadership, and operations leadership. And sometimes a change in leadership can really be an opportunity to get somebody to really champion your vision for collaborative care. So look for those opportunities to do that. And then it's really important. We found it to be really important to go the extra mile to become really a core member of the oncology team, to volunteer for committees, to give grand rounds, to really be involved with the quality improvement processes in oncology, and to be really visible in the organization, so that you can have those opportunities to state your case, make your case for change. And then during those opportunities, really emphasizing the value proposition of collaborative care, and have that sustainable business plan ready to go when you have that opportunity. Next slide. So we were able to launch this pilot, get approval to launch this pilot, and all of the leadership was aligned in this. And we chose three clinics: breast, lung, head and neck, and transplant as our clinics to launch the pilot in. And we chose these clinics because of the clinical need in these clinics, but also the providers, our social workers and the oncology providers who are really interested in improving psychosocial care in their clinics. And so we did a very intensive 3-month training for all of our social workers, not just the ones who are involved with the pilot, but all of our social workers. And we actually were able to provide CE credit for these trainings, which is an added plus. And then we also included our other psychiatrists in the training. And the training, I'll go through that in more detail, but it ranged from processes and operations to the rationale for what we were doing, diagnostic tools, outcomes assessments, evidence-based treatments, etc. And so after the training, we were able to launch the pilot Our oncologist, by the way, got very brief kind of orientations to collaborative care as well. And the 6-month pilot was very successful, as I'll talk about. And we were able to present the results of the pilot to our medical executive committee leadership, and that included all the other medical directors of different and hematology clinics. And basically, when they saw the results of our pilot, they all pretty much wanted the model in their clinics as well. And we were able to roll it out throughout the entire um, uh, Fred Hutch. Next slide. So here's a snapshot of the table of contents for our training manual, and you'll find more details in this paper that we wrote back in 2020 in the supplemental materials. But as you can see, a lot of these topics we've actually covered in previous webinars in this ACCC series, but as you can see, the training, range from, the concept of collaborative care, the rationale to, the workflows and how we, think about clinical practice guidelines and treatment flows and outcome measurements, caseload reviews. Very, a lot of detail on, the conditions that we treat, potential barriers that we might encounter, and even billing. And even though we didn't bill at first, and then we also had a journal club to continue education for our team members. Next slide. And here are the metrics that we collected during the 6-month pilot. We carefully collected all the reasons for referrals during that 6 months, the diagnoses, the PHQ and GAD-7 scores, and response rates, as well as suicidal ideation over time, the time from referral to visit, the number and frequency of social work, psychiatry, psychology, and other supportive care visits, number of case reviews that we did for each patient, number and percent of patients who got guideline level depression, depressant prescriptions, and also we developed based on some literature and our own kind of development. We did provider and patient satisfaction surveys for all the patients in our survey, in our pilot. And these are the things that we presented at our leadership meeting. Next slide. And then I'm going to just spend a few minutes talking about some thoughts that I have on what has allowed us to sustain our collaborative care model over these past 15 years. And I divide them up into 5 main categories: organizational and structural factors, financial, team level factors, intervention factors, and clinician level factors. Next slide. So in terms of organizational and structural factors, here are some thoughts that I have on what would be important to help an organization sustain a collaborative care model. Number one is to certainly stay very mission focused, and to maintain a clear workflow for everyone in your team. And to use a PDSA quality improvement structure to always be thinking about how you can solve issues that come up, and and improve the process. And then, of course, negotiating adequate administrative time for your team members to do their work. In terms of the financial aspects, I think that it's very important to acknowledge that it's hard to as we talked about actually at our last webinar with our various presidents of our organizations, it's hard to have the billing pencil out in terms of paying for everyone in the psychosocial care enterprise. So it's very helpful to get FTE support from your cancer center and or your home department, in addition to paying good attention to billing processes as much as you can to bring in as much revenue as possible. In terms of a team level, the team level factors, members should always be aligned with your model. That probably goes without saying. But if you have people who aren't aligned and not committed to your model of care, then that can certainly create frictions. It's very important to continue to highlight successes and to promote ongoing, learning and feedback from all your team members to maintain standard work in all of our team members and to maintain a customer service culture. And what I mean by that is, our patients are our customers, but also our oncology colleagues are our customers. And I think maintaining that culture of, customer service is really, really helpful. And to be really nimble in terms of coverage so that, your team members can take time off, can take time to do, get their continuing education, things like that. And then in terms of intervention factors, keeping a very, very learning health system approach in terms of continuing to collect good data, because as well as we think that we're doing, we can always do things better, and things will come up, and data is what will allow you to ask for more resources, ask for changes in your resources that you're getting from your organization, um, and really set up guardrails. In real world implementation, you're always going to have some what we call drift when things aren't going exactly as you had planned, and also what I mean by voltage drop is that there can be some kind of diminishment in the effectiveness of your intervention, no matter what intervention it is over time, because of competing factors, environmental factors, differences in turnover and staffing, things like that. So you want to set up guardrails to really catch those quickly and correct those quickly. And then finally, in terms of clinician level factors, really empowering your team to be a part of problem solving and innovation. Innovation's really, really important because people want to try new things and be creative, and we really, really encourage that. And collaborative care is a great model to allow for innovation and flexibility. Encourage research, participation, encourage education and participation in writing papers, chapters, etc. And then finally, really emphasizing the principle of mutual support, which is really core to collaborative care and a reason why there's so much satisfaction among participants of collaborative care. So I'm going to stop there and turn it over to Dr. Wu and talk about her experience at Dana-Farber.
Great. Thank you. So again, I'm Carrie Wu. I'm a psychiatrist at Dana-Farber Cancer Institute. We've been rolling out collaborative care since 2020. And since then, we've established about 14 collaborative care teams really across multiple regional campuses, in addition to disease centers on the main campus. We're actually starting 2 new teams this month also, and are on track to roll out completely across the Institute in 2027. So, with that, here I'm hoping to really share some practical strategies we've learned along the way when it comes to engaging and preparing oncology teams for that pilot, right? Or transition into collaborative care. And so, to start, I would say it's really important to have leadership buy-in. I think, you've heard a fair amount of this already from Dr. Fan. But even if you have institutional or senior leadership support, we learned it's actually helpful to have buy-in at the divisional leadership level, right? And depending on the size of the cancer center, or the cancer spaces that you're in, the divisional leaders are the ones who are helping to prepare the oncology workforce under their direct supervision and be a champion for your cause, especially if you're worried about groups who might be more vocal than others. And then once you have that buy-in, going to the divisional meetings and having face-to-face time, kind of that orientation meeting, initial introduction to what collaborative care is to the oncology providers, really explaining what it's going to look like for them, for their patients, and what are the changes that may be coming. And like anything we do when it comes to learning, giving presentations and listening to that first orientation, it often is just not enough. And so that's where really the on-the-go training and education comes in, which I will explain more as well. And finally, we'll talk about some of the strategies when it comes to soliciting feedback, especially if we want to get the most constructive feedback that is useful for developing this process. Okay, so next slide. So to start, we're introducing this model to oncology providers, right? It helps to shift the focus a little bit in the sense that we're not just illustrating unmet, mental health needs and the psychosocial needs in oncology, but really think about what is affecting the oncologist, what is affecting the oncologists and their population, the things that they really care about, right? And things that we also care about. So mutually understanding. And how, I mean, just for example, the fact that, approximately 50% of patients screen positive for distress, and how unaddressed distress directly impacts treatment adherence, affects outcomes, affects quality of life. And we also learned, trying to use some familiar lingo, like in our terms, when we're thinking of PHQ-9 or GAD-7, we're calling them maybe measurement tools. And oncologists and sort of in that culture are very familiar with this idea of patient-reported outcomes. So whenever we can try to connect on some level that they're really familiar with, that can be helpful as well. Next slide. So when we do go and meet the oncologists, there are, we found that it's helpful to really describe the model in lots of different perspectives. And so I've laid out here 4 potential perspectives to consider taking with you. And these are things that we have used, which find particularly helpful. One is really providing an overview of the model that helps show what all the relationships, how they connect to each other, that interconnected relationships, right? It's kind of the classic collaborative care diagram you may have seen with the patient in the middle, surrounded by the care manager. In this case, it's our social worker, the oncologist, the psychiatrist, and really like who's interacting with who, how frequently. That's sort of the model that I'm talking about. And 2, next is a process map. And that's really a map, a sort of a diagram to really demonstrate how patients actually move through the model, providing this visual from, okay, like what happens from referral to the first evaluation with the care manager, followed by the team meeting, the shared care, reassessment in an iterative manner. So having that process map can really put things into context, into just like understanding how patients actually move through. And then the third is delineating each person, including the team members, including the oncologists, what everyone's roles and responsibility is to, right? What are each person contributing and what their roles are within the greater model. And then finally, we find that it's helpful to have really a slide just talking about like what is changing, what is staying the same. And that just helps reinforce some of the teaching. So, for example, in our case, we had a new referral work queue, or we expected that now every patient is going to be evaluated first by the care manager or our social worker. But then there's certain things that may be staying the same, like our emergency response system are remaining the same. So that just helps them click, okay, this model is changing and there are differences, but what are the things that are still remaining the same? Okay, next slide. Now, once you've laid out, like, let's say you give that introduction, you've laid out all the explanations, there are going to definitely be questions and concerns that come up. And we do find this comes up, it seems like a varying degree. Tends to depend on the disease center, maybe the location of the teams. And some of it, sometimes it's related to expectations, often based on what the existing psychosocial resources are. Like that leads to fears about either that they're going to get less or maybe that they're getting more, especially in places that have very little resources to start with, right? So I think there's the expectation piece. And sometimes some of the, challenging concerns that really get brought up is around this fear that we're asking these busy oncologists to take on even more additional tasks. For example, this idea of I don't feel comfortable prescribing antidepressants, or I have enough to do already. I can't take this on. And so what I would say about that is often when these type of resistance comes up, it really is often rooted in fear and not opposition. And it's really like, what is that underlying fear, right? This underlying fear is I'm going to be alone in this and I'm going to be managing psychiatric care. And or that you're not going to see the patients that I'm really worried about. And so and this may be coming from oncologists who actually are already doing a lot of what we're asking them to do or participate in this model as well. But the fact that we're even naming it, I think makes that fear a little bit more abundant. And so we really try to tackle this through a variety of way. Um, Again, engaging with leadership, having champions around this, being very, very available, and being really embedded into as much as you can to be a core member of the oncology teams too, and really just demonstrating. So like walking the walk and not just talking about it, that you're there to provide more support rather than less support. Now, this is actually, next slide, please. This is actually where on-the-go training and education I find really, really helps. So the oncology engagement is, I think this is actually where the bulk of the engagement comes from. Not from that initial meeting, but it's actually like real-time learning. So when, especially, in the beginning of the model, when everyone is still new, having really regular, frequent communications about patient cases that you're discussing, providing feedback from those collaborative care meetings, really reinforce the model and what you're trying to accomplish. So, like, for example, whether you're recommending behavioral interventions, medications, or direct psychiatry consultation, like, send a message. Provide some brief rationale why you're doing this. And also like providing a pathway to stepping up the care. Like, hey, this is the first line or the gold standard, but if symptoms persist, we could try this instead. So it really shows them what you're thinking. It gives clarity, and it really allows for flexible discussion on how do we actually care for this patient. And so I find that these messages really help actually engage oncologists, both in the short term and in the long term as well. Next slide. And so finally, soliciting feedback is such an important part of engaging oncology teams, right? And what we have learned here, though, is that if we go in completely open-ended with no guided questions, sometimes we get either silence, lack of feedback, or this initial wish of, oh, we wish we were, there were more psychiatry staff or psychosocial staff. So we've learned that actually we need to go back to the basics a little bit, which is really asking about their understanding and operationalization of the model first, especially like if this is a new model for everybody and it's a pilot, so basic things like, is the flow of your patients actually matching the model that we're describing here, right? Like, do they actually understand the model? And are patients actually moving through the way it's intended? Do they feel equipped? Do they have that right language to describe the model to their patients? And do the patients seem to get it when that happens? Or when they get recommendations from the collaborative care team, how helpful is that, right? What's working well? What are some barriers and what questions? So like then opening it up a little more broadly. And so we find that, if there's a knowledge gap about the model itself and that operational piece, it's hard to even talk about whether the model is effective for patient care, because we really need to still boil down some of the basics pieces. So that's, so those are some of the things we've learned from Dana-Farber that I hope that are, give you some practical ideas around how to approach and engage oncology and really prepare oncology teams for that initial pilot. And with that, I'm going to turn it over to Dr. Pearl.
Great. Thank you, Carrie. That was really excellent and really excellent too. Jesse, I am going to finish us out by talking more generally from the perspective of someone who's done this across different systems, thinking about metrics for pilots, thinking about engagement efforts, and then maintenance and sustainability, things that you should be thinking about in your programs. Before I talk about metrics, which everyone is always really concerned about when you're doing a pilot of, oh, we need to get the metrics right, and that the metrics are really what is going to be driving whether your program is successful or not, or seen as successful or not, or having the potential to be expanded, might not actually be as important as you think they are. Because from what I've heard from other people and things that I've read, the programs that fail usually don't fail because of the metrics. The programs that fail in 4 different ways. The first is the programs that are never able to launch, that aren't able to get beyond the planning aspects, whether there isn't consensus among the different team members to move forward with things, or conflict among the team members to move forward, or there isn't a clear leadership structure pushing things forward or driving things forward. So failure to launch. The second place where people fail is not implementing the full model. One of the psychologists who's on my team now at Memorial had worked at a place saying we had done collaborative care in primary care and it doesn't work. It failed in the place where he worked before. And as we were doing some training about the model, he's like, oh, case review meetings. We didn't have case review meetings when we did collaborative care at this other institution. And I was like, how could you be doing collaborative care without case review meetings? That's a critical piece of it. And then I even thought about my experience at Dana-Farber, where we tried to launch one of our teams when we didn't fully, in this particular site, didn't fully have the electronic administration of the PHQ-9 and GAD-7s. And so didn't have all the pieces of the model ready yet for the launch. And that launch stumbled in the beginning until we were able to get those pieces in place. And so not implementing or not including all the necessary pieces of the model, you can lead to failure. That's the second one. The third one is financial planning for it. That I've seen models fail that were successful, that had been funded by philanthropy funds or a special fund that the hospital set up. And these funds had finite amount of funding in them. And when they ran out, there wasn't a plan for how to sustain this beyond that. And you can't just continue something without funding. And as everyone knows, it can take months or years sometimes to line up funding. And so some very successful programs went bust or stopped because of that. And then the fourth reason why programs have failed is changes in leadership. If it may be a successful program, but there may be a new leader in one of the stakeholder groups who's just like, nah, we're just not doing this, or I'm just not into this. And they were able to have enough influence to have it not work. And so although metrics are really important, I think those are the four areas that really lead to failure of collaborative care, that usually if you can put all these pieces in place and maintain it and plan ahead for finances and have consistent leadership, you should be able to do well. So next slide showing some metrics that you should think about for your pilots. I think when people start to think about metrics, we as clinicians immediately jump to outcomes of we want to show that we're giving patients better care and moving the needle more on depression and anxiety, or we want to show that we're doing better quality of care. Well, you're probably not already measuring those things in your practices to be able to say that the pilot is going to make these things better or that the pilot is an improvement on that. So unless you're in a place that already routinely measures this stuff, it may be hard to say that outcomes are better or quality is better if you didn't have that before. However, as Jesse described in their pilot, they were able to descriptively describe what the outcomes were in their pilot to show that if you do this, here's what the outcomes were. So even though it may not be comparative to say that this is necessarily better than before, it is some data to say what we're doing works. That it's just not some made up processes that we're doing that don't lead to anything, that here's what we're actually doing. The font color is not great for the next two things that I think are actually the most critical things about access. I think anything related to access are high impact metrics for this, for your pilots. So metrics like volume, you should have metrics about what your volume currently is before the pilot with a certain group of practices. And then you should have be able to have the data of here's how many people we were able to see through the model. So you kind of want to make sure that you're seeing at least as many people as before, but hopefully a significantly higher volume than you did before. And then wait times. So part of access is wait times to see a clinician, to see clinicians by discipline. That one of the things that's often a problem in cancer centers is wait time to see a psychiatrist, which can be anywhere from a couple of weeks to a couple of months. And in this model, if people are able to get psychiatric recommendations in the first case review meeting after they're seen by the care manager, you can get recommendations within a week. And that may affect the volume enough for general psychiatry referrals to make referrals to actually see a psychiatrist more quickly too. So you may be able to show some decrease in wait times by discipline. Satisfaction of both patients, oncology teams, as well as the collaborative care team members themselves, I think are also valuable metrics. Jesse talked about the surveys that they did. Carrie talked about some informal ways to collect this data from teams. But I think one thing that is also useful to do is to collect it from the collaborative care team members. The Fred Hutch social work team, I think, did that a few years ago. Tiffany Courtnott published a paper in Psycho-Oncology about the engagement of social work in doing this. And I think with all the concern about burnout and workforce sustainability, of showing that your team is satisfied with practicing this way is a valuable metric. And last is billing, that you may not bill during your pilot, but you might be able to model, like if we were billing, if the care managers were keeping track of the time they're spending on each patient and would bill for that, here's how much we would have billed, given what we were putting into this, to help think about the sustainability of this from a financial perspective. Could be another good metric to think of. Next slide. These are things that I think are important for engagement. So one thing to keep in mind is after you launch the pilot, like you're not done. Like it's not like we did the pilot and now everything is set up and we're just going to sit back and let these processes take care of themselves. No, there's continual maintenance. It's like buying a house. Like there's always something to do and something to fix and something to improve upon. And this is the same thing, that you should have periodic check-ins with the oncology team about the service. They might start to develop certain ideas about things that you're doing that may not be accurate based on one thing that happened. And so keeping everyone on the same page about what you're doing and making sure you're meeting their needs are good. One of the things that at Dana-Farber, one of our regional sites did was develop office hours for oncology APPs. That since oncology APPs were often the ones implementing some of the prescribing recommendations, of having an hour a week where they could just drop in and learn about psychopharm stuff or get questions answered about symptom management. And that was a nice way to engage the team and to really like embed yourself in the team and be part of the oncology team, both of what Jesse and Carrie were talking about. One of the Dana-Farber sites, oncology collaborative care teams, also developed a support space for oncology faculty. And some of the feedback that we had gotten about, is this model helpful or not? They were like, sure, it's helpful for patients, but we need help too. And so two of the clinicians ran I can't remember, it was monthly group where oncologists could come and talk about difficult patients from their feelings perspective around it to help them in managing that work. And I think that made a big difference to really being seen as part of the team and not of increasing your value to the team, making sure that all of what you do is visible and including as many people in that visibility as possible. So if you do a pilot, do a presentation on it, invite as many people from the different stakeholder groups to be part of it, do publications, be in news articles from your organization to let people know what you're doing. That gets people excited. People like to be part of innovations, groundbreaking stuff, new stuff, things that are successful. So try to make all of that visible. And then thinking about educational programs, things that can continually train both the oncology providers as well as the clinicians too. That I think one of the fears of collaborative care clinicians is this just going to turn me into doing a script or a robot and everything is going to be rote and I'm going to be doing the same thing over and over again, which is not true. And so by having educational programs with new skills development and stuff is a way to really keep people engaged and helping people continue to be their best and to provide the best care that they can in new and different ways, even though we're using this framework of the collaborative care model. Next slide. And this is my last slide of just thinking about maintenance and sustainability. I think the best thing to maintain and sustain these models are to provide access to patients and good care. Like if you don't have that, it's not going to be able to be sustained. So that's really the foundation of making sure that you're managing access and providing good care. The engagement efforts, all the things I was talking about on the slide before, is really also part of maintenance and sustainability. That really builds trust partnerships and goodwill towards all of this, which I think you need those in all aspects of life. And this is one way to get it for the collaborative care model. As Jesse was saying, you do need to monitor for drift in the model, that as you practice, you may notice like you're starting to cut corners, or you may have had a busy case review conference or case review meeting, you didn't quite do things, and you may drift from the principles of collaborative care. One example of drift in one of the teams that I was the psychiatrist for is we noticed that we weren't always identifying the target with each of the discussions we were having about patients, that we would discuss the case and talk about what to do, but we didn't explicitly talk about the target in each one. And so in order to help with that, we made sure our team notes from the case review meetings had to fill in the blank of like what the target was for that patient to help us stay true to the principles. Because like I said, one of the things that contributes to the collaborative care model failing is not actually doing the collaborative care model. And so making sure you're staying true to the principles, making sure you have continuous skills development so everyone stays engaged, can be up to date with the latest interventions and medications, and excited about the work that they do. And like I said, it's not over once you launch. Issues are going to come up when there's any changes in process at your practice outside of what you do. If there's a new health record, if there's new workflows about chemotherapy and stuff, all this stuff can impact your practice too. So you need to have some operations team related to making sure screening is working as you need it to be, ensuring the workflows are smooth, making sure documentation is being done and appropriate, and then dealing with oncology relations, that this is a continual maintenance and sustainability thing. The maintenance and sustainability isn't as hard as it was maybe putting it all together in the beginning. So it doesn't take that same amount of work or effort, but it does take some ongoing work and effort to keep everything running smoothly. Kind of similar to having a car or a house. You need to do things in order to have those things be maintained. And I think that's our last slide. And so we really tried to leave time this time for questions. And so I think we can open it up for questions now.
While we gather those questions from the Q&A session, which I think there's 2 that have yet to be answered, just a reminder that this is part of the 4-part series around collaborative care. You can find the other webinars here on our website, as well as additional resources around collaborative care model. But the first question that has not yet been answered in the Q&A says, was the Journal Club successful in getting meaningful engagement from providers?
Yeah, I can answer that. Yeah, I think it was very successful. We were able to integrate some of our trainees in that too. So we had our trainees and our social workers and attendings all contribute to the Journal Club. And it was just a really fun way to stay up on new treatment innovations and add that kind of extra level of education and academic interest into it wasn't every week, obviously. It was every couple of months, but it was a really, really fun and popular aspect. And I put together a little template of of kind of how to do a journal club, and it was really low key, so there was no pressure on folks to to present anything too intensive.
Great. Another question, or I guess a comment in here, is experience implementing collaborative care in centers without psychiatrists, but who do you have robust support services from otherwise? Nutrition, spiritual care, nurse navigator, social work, peer support. So I think they're asking what additional services are part of the collaborative care models.
I think what we've been saying through a lot of these webinars is you can expand the model to have it cover all support services. What we've been talking about over this whole series is really the framework of the different pieces that makes this an implementation strategy for evidence-based care in cancer. And if you follow these principles, you can incorporate other non-mental health supportive services into the model. That will take some thinking about how to do that, how to incorporate different disciplines in some of the pathways for treating common presentations or conditions that come up in cancer centers, but it's totally doable.
Great. There's another question that says, how would you recommend I go about advocating for this model in a cancer center in which I supervise but do not work full time? While the psychiatrist, social worker, and medical director seem supportive, there is no psychologist for adult employees. Everyone is super overwhelmed. I'm not sure anyone would champion this from within. Would you suggest applying for grant funding to go this way? Have you found grant funding for integrating this into integrating has been a big thing to move the needle in the past. So what funding mechanisms would you recommend?
I can just jump in that, when we did our pilot and when we launched, we didn't ask for any more money. We basically had our staff, our providers, reorganize what their roles were in a way that was much more well coordinated, much more collaborative. So what usually happens, I think, is that if you have the people in place, if you have social workers, if you have a prescriber, we talked about this in a previous webinar too, in terms of who the core role players are in the collaborative care model. A lot of the work is kind of reorganizing the roles and not needing a lot of extra resources, if any, at least to start out. And what happens is once you get rolling, once you get the model rolling and built out, then you can much more easily ask for more resources because you're providing much better care. And as your cancer center grows, then you're more poised to get the resources that you need to keep up with that growth. But Carrie and Bill, do you guys have anything more?
Yeah, so I agree with Jesse, and I think at both Dana-Farber and at Memorial, we got some resources to do this. But it was in the context of like, we need these resources and we're asking for less resources than we would be asking for if we weren't doing collaborative care. So in a way, asking for less than what you would be doing otherwise. I feel with this particular situation, you really need to have someone on the inside who's driving this. If there are people who are supportive of it, but just like, I just don't have the bandwidth or this isn't my thing, like, I don't think it's going to be successful. Like, you do really need someone who's like, I'm going to see this through in order for it to be successful. So maybe in your supervision, you can help drive people's thinking about it or motivate them to see that a change is needed, that they might be wanting to be that person to drive this. In terms of funding for this, I know people have used philanthropy at times to get new projects done. I don't know of any specific grant mechanisms to fund implementation of something like this. That's not a implementation science grant. I do know that, and I'm not sure if anyone from this group is on this webinar, but there's one site who came to one of our office hours who did get a grant to be able to implement collaborative care in their cancer center, but I don't know what that mechanism was.
Great. And then there was a clarification question in here. Can you have collaborative care model without psychiatrists, but other robust social services?
So
you can have,
yeah,
go ahead, Bill.
I was going to say, according to the current CMS definition of collaborative care, in order to do the billing codes, team meeting with a psychiatrist is required, or a psychiatric prescriber. I think a psych NP would be equivalent to that. So that's if you want to do billing. I think there may be that piece of it. Jesse, do you want to say what you were going to say?
Yeah, I was going to say the same thing. If you don't have a psychiatrist, you can have an NP or PA, so some sort of psychiatric provider to make recommendations. But yeah, it doesn't have to be an MD or DO psychiatrist per se.
I also just wanted to add that, when we're talking about like, can you implement collaborative care without a psychiatrist? Like much of the literature is often, built around, for example, targeting PHQ-9, GAD7, and using psychiatric, psychotropics in addition to behavioral management to try to target those symptoms, right? When we're talking about the other robust support services, even as they're robust, I think there's just less literature. Like the reason I bring this up is because, at Dana-Farber, we have palliative care. But one of the things that I will say we may struggle with is like, what is the right thing to monitor and target within palliative care, right? Like, what are the palliative care specific questions? And I would say that's something that we haven't like fully figured out. And there isn't sort of a ready to go kind of, this is what it's written in the literature. So we're figuring this out. I don't think it's impossible. I don't think it would be the same thing as, I think it's built on the collaborative care model, maybe for other services. But when we're talking about specifically for a mental health service, I do think that a psychiatric prescriber is still necessary.
And I think along that line, and I think a psychiatric prescriber is necessary for billing, but the psychiatric consultant is also critical for non-medication recommendations. So, whether it's a MD or a nurse practitioner or PA, that person needs to be, needs to have the knowledge and training to not just say, start this patient on this medication, but also to provide some recommendations for, hey, maybe try this psychotherapeutic modality, or did you think about this type of referral or things like that? It's a really kind of very collaborative approach, but it's not all just about medications.
Okay, I think we have time for probably just one more question. It says, what do you do about survivorship or post-active treatment patients, whether there are initial referrals or patients or already part of the collaborative care model?
So collaborative care is a framework for delivering care that can be used for any type of population. So I'm not sure if this question is, if you're in a cancer center, do you see cancer survivors as part of the collaborative care model? I would say yes, that probably all of the collaborative care teams that I know probably see cancer survivors to some extent. But I do think try to prioritize patients currently in treatment. Um, um, Jesse or Carrie, do you want to comment on that?
Yeah, I mean, I would say like I'm just looking at the question. It seems like there's another part to the question, right? The oncologist sees the patient far less and wants to take on more of a consultant role than a PCP role. And that seems like a major engagement barrier, which I completely agree with. If a patient is coming in and they're seeing the oncologist say, it's one thing they're coming in every month for an infusion or whatnot, but when they're coming in, say, every 3 months or actually every 6 months, that's to ask the oncologist to start a medication. I agree. Like in those cases, we do start to then at least use our collaborative care space more as a triaging and redirecting. Like sometimes we may take on some of those pieces and in more urgent cases, we may actually reach out to the PCP to start something. But usually, if something is identified, we try to think about how do we get them more support in the community rather than kind of taking on those direct treatment, mental health treatment pieces.
Hey, with that, I think
Yeah,
we are. Oh, go ahead, Dr. Fan.
I was just going to say, please bring your questions to further questions to our office hours in August, because we can delve into some of these types of questions in much more detail. Because yeah, we're not able to get to all of them today.
If you are interested in joining us for office hours, I've put the registration link into the chat, and we look forward to seeing everybody there. But with that, on behalf of the Association of Cancer Care Centers, we'd like to thank you for joining us today for part 4 of our 4-part webinar series around collaborative care models. This webinar, along with the others, will be available on our website if you would like to see those, and then continue to participate in office hours going forward. So with that, thank you all for joining.